Hello, I'm Rachel Deer, host of today's program, COVID-19 Keeping Up with a Moving Target. Thank you for joining us. This activity is jointly provided by the Postgraduate Institute for Medicine, DKB Med, and the Institute for Johns Hopkins Nursing. Today's program is accredited for ANCC, AAPA, and AMA PRA Category 1 credit. Please visit our website for complete CE information. If you're tuning into our webcast, please click the Claim Credit button on the webinar console. Otherwise, please go to covid19.dkbmed.com, navigate to our multi-specialty episodes, and select this webinar to claim credit. Today's learning objective is discuss the various treatment options currently available for outpatients at risk for severe COVID-19. This educational activity is supported by independent medical education grants from Gilead Sciences, as well as in-kind support from DKB Med. With us today, we have Dr. Paul Auwaerter, Clinical Director of the Division of Infectious Diseases at Johns Hopkins School of Medicine. Dr. Auwaerter, welcome back.
Thank you, Rachel, and thank you for joining us again as we try to keep up with the COVID pandemic. And the Omicron variant has certainly caused quite a ruckus across the healthcare system in the United States from December onward through the holidays. The number of cases have been substantial, the highest ever. And of course, this is likely an underestimate as the ability to get tested, whether by molecular means or antigen tests, really proved difficult over the holidays and now into January. And here we are on the 19th of January. And luckily, nationwide, we may be past peak. You can see a small dip that may reflect the Martin Luther King holiday. But many states have already had fewer people in hospital, for example, in New York, DC, and here in Maryland. And so this is a hopeful sign that the quick uptick also will have a rapid downswell, which has been true for South Africa and some other countries. However, some states which weren't quite as affected in December, for example, Florida and some of the other southern states are now still on the upswing. So we'll hopefully have a higher but quicker peak than some of the other peaks that you've seen here. I think the other aspect that's quite important is if you look at the sheer number of cases and compare it to hospitalizations and death, I think this does substantiate the fact that the Omicron variant is likely less virulent than earlier variants such as Delta, especially if we have more unaccounted for infections than we've had in the past. But as a variant comes along, Omicron has very quickly displaced Delta in a matter of almost a month. From a small percentage to now nearly 99% of isolates sequenced in the United States represent the Omicron variant. And this is important for some of the therapeutics that we'll be discussing today as you're thinking about patients. But testing for COVID has become quite a chore with the onset of the Omicron variant. Many testing centers had closed or had reduced their capacities. So many people looked to the antigen tests, especially over the holidays, when it was very hard to find any kits on any of the pharmacy or other store shelves. The White House has announced that they are shipping antigen tests now for home in a way to help mitigate some of these difficulties in finding tests if people have symptoms and want some reassurance. But a couple things I think are quite important. First, even though we're dealing with the Omicron variant, even earlier in the pandemic, antigen testing really did not perform quite as well as molecular testing. And the reason why this might be more important with the Omicron variant is perhaps the speed that this variant is able to quickly incubate and produce a productive infection. So, for example, you might swab and test someone and it's negative, but 12 hours later or the next day would be positive. And this really has to do with the limits of detection. And this preprint gives, I think, an idea of why the antigen test may not be performing as well. And there's also some concerns that Omicron may not be replicating quite as much as earlier variants in the nasopharyngeal passageways, where traditionally the swab has been considered the gold standard in that area as opposed to elsewhere. So this particular preprint compared people who were PCR positive with symptoms, and what they found was that if you had a fairly significant viral load of over 100,000 copies, that the antigen kit, the Binax Now kit, detected either Delta or Omicron. But once those levels fell to 20 to 70,000 viral copies per swab, that was about the best it could do. This will be a hundredfold or more or less than the limited detection for PCR. So, PCR remains the gold standard, but many people have been critical of the test because they will check and they'll think that they're in good shape with a negative test, but yet still have an outbreak in their household or something along those lines. And I think what is prudent, if it's at all possible, is that you're concerned about an exposure or you have symptoms and there's a negative test initially on an antigen, it may be a false negative and you may want to test yourself the next day to see if you can register a positive test. Now, this is a rather busy slide, but I think it contains a lot of important information that has evolved rather quickly since December onward. And it reflects a number of things. First, you don't see casirivimab and imdivimab, the Regeneron product on the slide, or bamlanivimab, etesivimab, those two monoclonal antibodies, which have been very successful in keeping people out of the hospital and with severe illness. However, the Omicron variant unfortunately eludes activity of those monoclonals. The only monoclonal that's left with activity is sotrovimab, which has been in quite short supply, but has been distributed still by Health and Human Services. But certainly here in Maryland, it's a limited supply, so only the patients with highest risk, like solid organ transplants or people who are immunodeficient, have been prioritized to receive this if they're infected. But this works quite well, even though the actual information that got the EUA authorization was an interim study. But the big news has been the top two rows, and that's the oral antivirals that have now received emergency use authorization. And Paxlovid, which is a combination protease inhibitor boosted with ritonavir, has performed well with over 80% reduction in people who took the drug and avoiding hospitalization or death in the month after acquiring the diagnosis. It's not fair to really compare these trials one-to-one, as they were all done at different times. But if you look at the number needed to treat, you get the idea that regardless, even though there's an 88% reduction in hospitalization, the number needed to treat to actually achieve and avoid one hospitalization is 18 people. So it's not as though everyone develops severe illness and so on. And of course, these were done in people who had at least one risk factor for severe COVID-19. Now, the protease inhibitor certainly performed well in this study, but does have drug interactions. So some of the issues with ritonavir, which is common to anyone that treats HIV patients, knows that this is quite problematic, for example, in transplant patients that might be on tacrolimus, sirolimus, and other drugs there. So what's happened is a authorization by the FDA for remdesivir, which we've used in hospital for a 3-day course in early disease outpatient infusion, which had a laudable decrease in progressive illness, as you can see, nearly equivalent to Paxlovid, although the numbers and the percent impact were a bit lower. Unfortunately, this is a 3-day infusion, and even though Medicare has issued a J code for remdesivir, the logistics of getting an infusion in the outpatient arena is certainly problematic. Therefore, coming in last is molnupiravir, an oral antiviral. This nucleoside analog initially was touted as having a 50% reduction. When the larger numbers of the study were presented to the FDA, it turned to just a 30% reduction. However, there are no drug interactions. It appears relatively safe, but you can see the number needed to treat to avoid a hospitalization or death is 34 and substantially higher. So the drug appears to be less effective. And then last, convalescent plasma had a reauthorization by the FDA only for immunosuppressed patients. A study that is still in preprint did show success in the ambulatory arena if it was infused early, on average 6 days of symptoms. And this study, though, included all comers with risk factors, but the FDA chose to limit it to people with immunosuppressive illness. So that's the sort of armamentarium that we have for early COVID-19 illness. There is not abundance of any of these products. So unfortunately, it is a bit of a hunt to find the right treatment and availability for our patients, which certainly consumes time. So many patients, especially transplant patients, have held out for pre-exposure prophylaxis. You know, they don't respond well to vaccines. So the hope was that a long-lived antibody with about an expectation of 6 months of protection per intramuscular injection is tixagevimab, acilgavimab, a combination. And this study, the PROVENT trial, was in a large number of people, and their primary endpoint was just prevention of infection. You can see the numbers here were small, but it did show a 77% reduction there. And of course, this was all done before the Omicron variant came to fore. However, it's 2 injections, and just given the kinetics of this monoclonal antibody, there's no protection for the first 2 weeks. This particular trial had very few immunosuppressed patients, but that's how the FDA has positioned this particular drug to be used as a prevention for people that are immunosuppressed or don't react to the vaccine or have a contraindication to receiving the vaccine. The data only went up to 83 days, even though it's a 6-month trial. So these are interim results. And of course, it was all done before Omicron. And the NIH has this handy chart here where all the gold dots represent in vitro studies of antibodies or sera of immunized people against the Omicron variant. And what you can see is that the drug Evusheld, which is the combination monoclonal we just spoke of, seems to be less active against the Omicron variant, but has more activity than you can see compared to the Regeneron combination monoclonal or bamlanivimab etesivimab. So the hope is it has some protection. However, there already have been some breakthrough infections, but it's important to know that a drug's just been rolled out, and there's no ability for these long-acting monoclonals to provide activity in the first 2 weeks. We know from the Storm Chaser trial, where this monoclonal, the Evusheld, was given and really offered no protection post-exposure prophylaxis because it takes a while for the antibodies to get to tissues after intramuscular injection. So, Rachel, lots of information there, but hopefully helpful to try to help make some decisions with your patients on how to proceed for either pre-exposure prophylaxis or treatment. Do we have some questions this week?
Yes, we do. With a limited supply of the drugs for outpatients, how are patients at high risk for severe disease being treated now?
Well, that's a great follow-up question from what we just spoke. It depends on your situation and how institutions and perhaps state health departments are dispensing drugs. I can give you an idea what's happening here in Maryland. Sotrovimab is being dispensed to hospitals, but also state infusion sites, and only high risk, the highest risk patients, those that might have B cell deficiencies or don't mount good responses against immunization, are being prioritized because it does seem that sotrovimab is probably the best performing drug out there, but it's an intravenous infusion. Paxlovid looks just as promising, but the supplies have been so limited that there's only been a handful of patients that have been able to get them at any given site or time. For example, I've only had one patient that's been able to acquire the drug before supplies are exhausted. I think molnupiravir is a drug that's a bit more widely available, but because it doesn't work as well, people are angling for those earlier two treatments. And convalescent plasma really had not been procured recently to a great degree. And now with this refreshed EUA, blood banks have to gear up to produce the plasma, and it's in quite scarce supply, and is probably being reserved mostly for immunosuppressed patients in hospital. The remdesivir, again, I see being used for a 3-day infusion in inpatients, not so much in outpatients, just because with all the staffing shortages and difficulties of trying to arrange a 3-day infusion, it's been quite difficult. So hopefully all these things will improve in the forthcoming weeks with hopefully increased supplies of sotrovimab and especially Paxlovid being planned through the spring. But one also hopes that the Omicron variant or any other SARS-CoV-2 infections will decline substantially as the winter moves to spring.
Thank you. And here's our final question. Is throat or saliva swabbing more effective than nasal swabs for detection of Omicron?
There's always been interest in salivary samples just because of the ease of procurement. You don't have to swab, and people generally like it quite a bit more. And in fact, I have had both done myself, and the saliva is certainly easier. Especially with the Omicron variant, there's some suggestion that this may preferentially replicate such that salivary sampling may be as good or perhaps even a bit better compared to traditional nasopharyngeal swabs. I think many of these looks have been quite preliminary. We'll gather more information certainly over the next few weeks. But I think moving ahead, there will be more options for salivary, especially testing on a molecular basis. I think on an antigen basis, it may prove more difficult, and you'll probably not see that come quite as quickly, but that is another potential possibility as well.
Thank you for those updates, Dr. Auwaerter. If you're tuning into our webcast, please click the Claim Credit button in the webinar console to attest for credit. Otherwise, please visit us at covid19.dkbmed.com. Again, thank you for joining us, and thank you for your dedication to your patients with COVID-19. Thank you, Dr. Auwaerter.
Thanks so much, Rachel, and hope everyone stays well and hopefully can do what we need for our patients who are suffering from COVID-19.